right, so hepatitis C. So what have you learned about it? What do you know? It is curable. That is a big thing, big thing. Okay, what else? Common in the baby boomers, so for some reason those born between 45 and 65 are at higher risk. Who else?
Associated with
IV drug users. So how does it transmit it?
mainly through blood.
Blood or other infected body fluids. Okay, what else?
It's actually pretty rare to get it from tattoos anymore.
It's rare unless you have a tattoo parlor that doesn't adhere to good hygiene, I guess.
The acute phase is very minimal.
Acute phase, not very many symptoms, almost all chronic phase. Most people who get acute will go on to get a chronic infection.
It's rare to get it via heterosexual sexual contact versus homosexual.
Yeah, I would think, I'd remember high-risk sexual practices. That's who will be common at risk. But some other common infections, so HIV, what's another common co-infection? AIDS and hepatitis B. So when you see them, think if they haven't tested for the other, test them for those. Okay. This is common. I saw it a lot in family medicine. In fact, the residents considered it to be endemic in that population. We just assumed they had it unless otherwise we had found out they didn't. Saw a lot in diabetes. Did anybody talk to you about the risk of diabetes in Hep C? So Hep C tends to confer or cause an insulin resistance, and that's since the liver, it increases resistance. And so your risk of getting diabetes if you are over 40 and have Hep C is 2 to 3 times the normal population. So if I saw Hep C, I always look for diabetes. I saw quite a few people like this, and usually I got them at end stage. So end stage, we almost always had to put them on insulin because we didn't have any other drug to use. And usually I was using little doses, like 5 to 10 units if they were fairly end stage, or I'd have to use humongous amounts of insulin because of the resistance. So remember that when you see a patient is look for the diabetes. So common comorbidities. Okay, I have a couple of videos. I really like these. One goes over, it should be reviewed for you, just kind of to set your brain. And the second one I like because it introduces drug therapy. I like the visuals that they give. So as we go through and talk, I think it will help set that. So I thought, I'm so like my old science teacher that I couldn't stand in 7th and 8th grade, Mr. Wittenberg. A veteran of the tenure system of Poplar Bluff, Missouri. He never taught us. I always had him for 6th or 7th period. He would assign a chapter in his science books, and then he would go and sit in the back, and he would pick his teeth with a burned out match. So whenever I post videos for you all to watch in class, I always think of Mr. Wittenberg, and I'm like, okay, I'm not him, but oh man, what a. It's a wonder I went into a science-related post. Okay, where did y'all tell me?
It's on the top of the board.
See it. So this is kind of the pathophysiology.
The hepatitis C virus is a major cause
This guy's
of
French,
chronic
so sorry.
hepatitis, liver cirrhosis, and hepatocellular carcinoma. The virus is transmitted mainly through blood and reaches the liver via the bloodstream. The virus circulates as a so-called lymphoviral particle associated with components of low density and very low density lipoproteins. The viral envelope glycoproteins are localized on the surface, whereas the nucleocapsid is located within the hydrophobic interior of the lipoviral particle. The nucleocapsid is formed of core proteins interacting with the viral RNA genome. Once the viral particle reaches the hepatocyte surface, it interacts first with glycosaminoglycans and syndicans, followed by binding to more specific receptors, including the scavenger receptor B1 and the tetraspanin protein CD81. The viral particle, complexed with these entry factors, reaches tight junctions and engages in further interactions with Claudin-1 and occludin. The viral particle subsequently enters the cell via receptor and clathrin-mediated endocytosis. After its release into the cytosol, the clathrin-coated vesicle interacts with the motor protein dynein.
Isn't that cool? It looks like Star
Dynein
Wars.
transports the vesicle by walking along microtubules to reach the endoplasmic reticulum area. Acidification of the endosome lumen induces conformational changes of the viral envelope glycoproteins, which in turn interact with the endosomal membrane, leading to fusion of the viral and endosomal membranes. Membrane fusion is followed by uncoating of the nucleocapsid and the release of the viral RNA genome into the cytosol. Binding and assembly of ribosome subunits on the viral RNA is the starting point of HCV polyprotein translation. A signal sequence located in the beginning of the translated polyprotein allows the ribosome to be targeted to the translocon on the endoplasmic reticulum membrane. Translation can thereby proceed further, giving rise to a polyprotein which is cleaved by cellular signal peptidases and by the viral proteases into 10 mature proteins.
Okay, these are important because these are drug targets that are coming up.
The structural proteins which make up the viral particle comprise core and the envelope glycoproteins E1 and E2. P7 and NS2 support viral particle production while not being incorporated into the particle. The replicase components NS34A, NS4B, NS5A and NS5B are sufficient to support viral RNA replication. HCV replicase proteins, in concert with host factors, induce rearrangements of the ER membrane, including the formation of double membrane vesicles. These vesicles cluster to form the membranous web, which represents the site of HCV RNA replication. Viral RNA synthesis is catalyzed by the RNA-dependent RNA polymerase activity of NS5B, which acts in concert with other viral non-structural proteins, as well as several host factors. After synthesis of a negative strand RNA intermediate, multiple positive strand progeny RNAs are generated from this template and either used for translation and replication or packaged into nucleocapsid particles. The latter process is thought to be initiated on the surface of lipid droplets that are targeted by the core protein. It is assumed that a network of NS5A delivers the viral RNA to core proteins for assembly into nucleocapsids. Nucleocapsids form at ER-derived membranes where E1 and E2 accumulate in conjunction with P7, NS2 and host factors including apolipoprotein E. The viral envelope glycoproteins are acquired by budding, a process which appears to be linked to the very low-density lipoprotein machinery. Newly synthesized virus particles are thought to be transported to the cell surface in export vesicles via the cellular secretory pathway. Finally, they are released from the cell by exocytosis to reach the bloodstream.
Aren't they incredible organisms? Okay. Okay, now we're gonna go across the English Channel, and this guy has a British accent.
A better understanding of the hepatitis C virus proteins, their structure and function in the viral replication cycle, has greatly improved our knowledge of identifying drug targets and led to the development of new direct-acting antivirals for HCV. HCV is an enveloped single-stranded RNA virus contained in an icosahedric protein capsid. The outer envelope has a lipid structure anchoring two glycoproteins, E1 and E2. The linear RNA strand is composed of approximately 9,600 bases, coding for a unique precursor polyprotein. Proteases coming from the virus, NS2 and NS3, and the cell itself cleave this polyprotein into two categories of viral proteins. Structural proteins, including the capsid C protein and the envelope glycoproteins E1 and E2, and non-structural proteins, NS.
Those are your drug targets.
The non-structural proteins include protease NS2, serine protease NS3, a cofactor for NS3 activity called NS4A, a regulator protein NS5A, and an RNA-dependent RNA polymerase NS5B. Viral replication requires the formation of a replication complex composed of NS5B, the RNA-dependent RNA polymerase, and other non-structural proteins, NS2, NS3, NS4A, and NS5A. Like most other RNA viruses, the HCV genome is highly variable. 7 genotypes with approximately 60 to 70% genomic homology are defined. These genotypes, numbered 1 to 7, have subtypes designated by lowercase letters, A through Z. Therapeutic agents with direct antiviral action have been recently developed and approved for certain genotypes. They target the different proteins required for viral replication, such as the serine protease NS3-4A, the multifunction protein NS5A, and the NS5B polymerase. HCV NS3-4A inhibitors, such as peretabravir, constitute the first of 3 therapeutic classes that will be discussed. NS3 is a viral protein with a helicase that becomes functional in the presence of its cofactor, NS4A. Functional NS3-4A is a serine protease that cleaves the other non-structural proteins, NS4B, NS5A, and NS5B. Like all protease inhibitors, NS3-4A inhibitors are highly specific and can be genotype dependent because of the variability in the NS3-4A protease amino acid sequence. Furthermore, the addition of ritonavir is necessary as a CYP3A inhibitor that increases the systemic exposure of peretabravir. Ritonavir is not active against HCV. Due to this variability, these new agents may be combined with other direct-acting antivirals from other therapeutic classes. HCV NS5A inhibitors like ombitazvir affect a second target, the multifunctional phosphoprotein NS5A. NS5A is implicated in the regulation of RNA replication and in the production of viral particles. It enables linkage with lipid droplets, and its interactions with other viral proteins are essential for assembling viral particles. Agents that inhibit the NS5A protein are essential in disrupting HCV viral replication. The third class of therapeutic agents are HCV NS5B inhibitors, such as dasabuvir. NS5B is an RNA-dependent RNA polymerase within the replication complex. It is the key enzyme for HCV viral replication. Starting with the positive sense RNA, NS5B synthesizes a negative sense RNA, which in turn it uses as a matrix to synthesize a new strand of positive sense genomic RNA. There are two inhibitory mechanisms, nucleoside inhibition and non-nucleoside inhibition. Non-nucleoside inhibitors, such as dasabuvir, are competitive inhibitors that bind to sites far from the site of action. This changes the conformation of the polymerase, causing it to lose its functional capacity. 3 binding sites have been identified, corresponding to 3 types of non-nucleoside inhibitors. The development of inhibitors acting at different phases of the replication cycle has enabled the creation of therapeutic combinations. Vicirax with Exvera combines 3 direct-acting antiviral agents with distinct mechanisms of action and non-overlapping resistance profiles to target HCV at multiple steps in the viral life cycle.
Okay, you probably talked about this when you talked about the in ClinMed. So he says 7. I'm not sure if he's counting 1A and 1B as separate genotypes. I've never seen a genotype 7 discussed, but maybe that is somewhere else. But worldwide, these are the common ones. In the United States, it's genotype 1 that is the predominant. It's the hardest to treat. So before we had these direct-acting antivirals, you just could hardly cure it in this country because the 2 drugs that they used, interferon and ribavirin, were so toxic that people had a very hard time completing therapy. So what I'm going to focus on for you all is genotype 1, and we're going to do treatment naive. People who are treatment experienced mean they have had a treatment in the past and they failed it. Those folks, I think, probably are going to have consultation with a GI therapist or specialist. When I was seeing these folks in family medicine, they were almost always treated and under the care of a GI specialist, usually somebody in liver. I don't know if that has changed in the last couple of years since the direct-acting antivirals have come out, and they are so effective that you may be using those in primary care. I'm not quite sure what to say. Who came and talked to you about that?
Sally Rohr?
PA or PA? So is she with a liver specialist or she's in family practice?
GI.
She's in GI. So it may be that these are still being handled mostly by GI. They are extremely expensive. So I would imagine also people are kind of keeping them in that specialty until the price comes down, possibly. But if you're in a family practice area, you will see this type of infection more often than you would like. Okay, so let's go over, you've kind of mentioned most of these things. At the bottom of page 1, you've looked at transmission. So your body fluids, the sharing of needles is probably the most common cause of transmission. Sexual intercourse with somebody who's infected can also spread it. Mother to child during birth. So keep those transmission lines in mind. We talked about the genotypes. Risk factors on the next page. Again, those who inject drugs. So if you are dealing with folks who are recreational drug users and they're using injectable types, then testing for Hep C is important. Those who have multiple sexual partners and don't practice safe sexual practices, then those would also be someone to look at. Incarcerated persons, it's like 60% of the incarcerated population has Hep C. And those who work in prisons are also at risk. So keep that one in mind. Blood transfusion, organ transplants, that's been a while, 1992. Blood products, if they have hemophilia, and we're using products before 87. That probably contributes somewhat to the people born in those 45 to 65. I think also you have to look at the fact that birth control pills came out in the late 50s, early 60s. So sexual practices, I don't know if they changed, but they could certainly become more frequent, more common. You had a drug that was very effective, so people may have experimented that maybe would have in the past. People delayed getting married, so all kinds of things that happened to that age group as they grew up. In terms of diagnosis, so a couple of things. One is that you would look for, test, or screen for antibodies to know if they have been exposed. And then there are several different ways to go. There is a test that can be confirmative, but from what I read, most people don't use it, but blood banks do. And that's that second RIBA for testing for the presence of HCV RNA. So that is a confirmatory, but from what I read, most people don't use it. Did she address that? Did she say? Okay. The next you can do is go to testing for viral load. That will tell you if there is active virus in the body. So I imagine most people go to that. You can do a liver biopsy, which for most of the patients I saw, they all have a liver biopsy, because then you can stage it for fibrosis, presence of cirrhosis. If you look on the very last page, you all may have talked about the Medivir scoring system. Did you talk about it? For treatment, they look at this. And so this Medivir scoring system looks at the activity that's in the liver, inflammation being part of it, and they also will stage the fibrosis. So where it comes into play for treatment is that the more mild the disease, so if there's low degree of activity, a low-grade fibrosis, you can treat for a shorter period of time. The higher the grade of that fibrosis, the presence of compensated cirrhosis, you can treat for like 12 weeks. If you have decompensated cirrhosis, those people are very high risk. They definitely have to be under specialist care, and their treatment can be much longer, like 24 months, or 24 weeks, sorry. So that's where this comes into play. And I'll show you, I didn't put the flow charts in your handouts because they're just so detailed, but I'm going to show you with one of them kind of an example of flow of treatment. If you look at the bottom, that clinical course is important because it is a very long process. The chronicity of this viral disease and what it causes is a 20 to 25 year period. So if you look there under clinical course, you see that cirrhosis, very common. Hepatocellular cancer, very common. Those are usually the two things that get these folks. And at about the 25-year mark, almost all of them have it, if not treated. I'm on page 2 in the middle. Presence or absence in scar tissue, that fibrosis, the cirrhosis, and then cancer. Those are usually the end causes of mortality in these folks. Comments about that? Anything else she told you that might be pertinent here to remember? Okay, let's talk about treatment. So there's 3 classes. The direct-acting antivirals are fairly new. I'm trying to think, maybe 5 years, in the last 5 years or so. Ribavirin and pegylated interferons are the old products. So people could have been treated in the past on those and been a treatment failure. And so they can be looked at for a treatment with these newer agents. Approach to treatment is important. Anytime you're looking at at a virus that you're trying to eradicate, HIV, you'll see this. You always, I don't know of any, I'm trying to think of one where you would have a single agent. Now some of those we've talked about, like herpes, we've used like acyclovir, 1. These more complicated immunosuppressive or more total body effects, they almost always require a combination of products that have multiple attacks of the virus. So you see there, they showed you those last 4 major proteins that are produced are structural proteins, proteins that are used in viral replication. Those are the big targets. And so we always use multiple classes. There's no single, I think there's only 1 instance in this where you can use 1 agent. So think combination when you think hepatitis C. Resistance, some of the drug classes have a very high resistance to mutations and changes that make the drugs ineffective. That's another reason to use multiple agents, because then the development of resistance is lower. So that's important. Duration will depend on how advanced the disease is. So fibrosis, cirrhosis are going to be kind of the markers that they'll look at. The lower the degree of activity, the shorter the time that people have to be on it. The good news is that the newer products, these direct-acting antivirals, are low toxicity. They will make them sick. They'll feel more like they have the flu. They get nauseated. But it isn't like ribavirin and the interferons, which are really hard drugs for people to take for prolonged periods of time. So that is a very good thing with these newer agents. Treatment naive, treatment experience will change what you do and duration. Okay, so treatment naive means they've never been treated for hepatitis C. Treatment experience means they have been treated and they have failed. What they have failed is important. So if you're dealing with someone who maybe was treated with older agents and they're coming in, it's really important to document what they took in order to determine what to put them on the next time. If cirrhosis is present or absent, will change usually duration. It may change drug. The more cirrhosis is present, then usually the more drugs we'll use, the bigger the combination will be. And the same with fibrosis, if it's present or not. Okay, so let's talk about the direct-acting antivirals. There are 4 classes, and they go after those 4 proteins that you have seen up there. So they're divided into the NS3, 4A protease inhibitors, the NS5As, and the NS5Bs. The NS5Bs are divided into two groups. One are and they're listed down there right below under 4 classes of direct-acting antivirals. You have the nucleoside polymerase inhibitors. There's only one, I don't know why I put it plural, but the NPI, and then the non-nucleoside polymerase inhibitors. The NPI is a very potent, it hits all genotypes, very, very good drug, always used in combination with something else as well. The NNPI is not as effective, but it's usually used within combinations to strengthen that combination. In the table that I gave you, the first section divides all of those drugs, gives you the 4 different classes. At the end of all of those drugs, I have highlighted or bolded the common ending to all of those drugs. That's the way I remember it. So in all of the NS3 4As, they all end in P-R-E-V-I-R, Previr. Okay? That's the way I remember it. That's the beauty of generics, is that they usually, when they set up a class, they make a common ending or beginning of the drug. Everybody following me? Okay. I want you to be able to recognize what drug goes with what class. So I'm telling you, because the names are weird, is learn the endings, okay? Then you can identify which class the drug goes with. With the NS5As, they all end in ASVIR. Okay. On the next page, with the NPI so these are the NS5Bs, they both end in BUVIR. There's only one in each class. So sofosbuvir is the NPI, and dasabuvir is the NPI. Okay, it's just all made up. On the last page of the table, I have put the combinations there. Sometimes I think it's just easier to remember. Some of these you'll see on TV quite a bit. Harvoni is advertised quite a bit. So they're listed with the different combinations and whether or not you use them with ribavirin and other medications that may be in it. Okay. So let's look at the protease inhibitors, middle of page 3. If you look down through there, we're going to look at what's common. So what's common is that these drugs are never used alone, so they are all marketed within a combination product with the exception of the very last one. So Cimeprevir, Olesio. It's the only single ingredient agent, but it's never used alone. So these others are formulated and combined with either an NSA or an NS5B. Olesio is a second generation, so it's higher, it's more effective against and resist changes better. All of these agents are good against genotype 1, and that was one of the reasons why they were found to be effective, and that's why you see so many of them. If you look down at the third one, Paritaprevir, it's in combination with several drugs, but it also is you see ritonavir in there. Find it, circle it. So ritonavir is a protease inhibitor, a different protease inhibitor. It has no efficacy against hep C. The reason they added it is they took care of its pharmacokinetics. It impairs the metabolism of the Paritaprevir, and so it keeps the levels up and keeps it around longer. So that's why it's added. Ritonavir. So the big thing to take away is that you know what, you can identify what drug goes with that category, always used in combination, always good against genotype 1. So you would see these commonly used, or patients on them common. And the action of ritonavir is to increase the action or the length of time that protease inhibitor stays active in the body. Questions there? Okay, NSA5 inhibitors. So again, that's that ASVIR ending. These are also always in fixed combinations with other agents. They are very potent. So what the term that you will see applied to them is pangenotypic, which means they apply to all genotypes. In this country, again, you're mostly going to see genotype 1. 2 and 3 are, genotype 2 and 3 only make up about 25%. And so they're just not going to be that common. 4, 5, and 6 you rarely see in this country. They tend to be more South Asia, Africa. So unless you have somebody from that area, it's just they're very uncommon. So I'm not even going to address those in terms of treatment. We're mostly looking at 1. I've given you information on 2 and 3. Again, they're very good. If you look at the last bullet here, very good, very high sustained virologic response. That's what that SVR, sustained virologic response. So very good against genotype 1. So you'll see them in the combinations quite a bit. If you look at the table, you'll see in every combination there's an NAS5A, every one of them. They're all different, each one of them has a different one, but they all have an NAS5A, okay? If you look over on page 4, the NS5Bs. The part of the virus that these agents attack is fairly stable, and it's common to all the genotypes. So resistance to, they are fairly high, they are resistant to resistance developing, and they're pangenotypic. So because that entity or that enzyme is common to all genotypes, then they're pangenotypic. Make sense? Unlikely that, and if the virus mutates and can get around that drug that you're trying to kill it with, it makes the virus weaker. So you have wild types, and you have ones that have mutated, but the mutated ones they call not fit, so they're not as viable. They just don't do as well. So even if they mutate, they're not as strong a virus. Does that make sense? Okay. There's only one in this class, one in the other class. The other, and I put it in there, is that there have been others developed in this class, but their toxicity profile is too high, and so patients have been unable to tolerate those. So that's why you only see a small amount or only 2 in this group. The non-nuclease polymerase inhibitors, Dasabivir, it's mostly after genotype 1. So whereas Sofosbuvir is all of them, this other one is mostly genotype 1. So you'll see it in use as well. Again, if you look under the fixed dose combinations, they're always going to come in combination with another drug. They are so effective that usually when you see them in combination, it will just be with one other drug. So Harvoni has Sofosbuvir. So does Epclusa and Vasavi. You'll see under the fixed dose combinations that ritonavir shows up again. Remember what its value is. Okay, let me see. If you look on the top of page 5, that last one, Vasovi, that is a new one. It is one that it's very potent. It's mostly used in reserve for people who have failed an NS5A. So that's another one when you are talking to patients about that are treatment experienced, ribavirin, interferon use, and also were they on an NS5A and they failed it. Because that's one of our real strong classes. If they have failed that, that poses a problem in what do you use next. Okay. Most of the time in the treatment flows, you're going to see that when you've got treatment failures or you've got patients with decompensated cirrhosis, those they really recommend having a specialist involved. Okay, so I put a lot of detail in here. You can tell from the way I'm going over it, I'm not going to expect you to know that. Go by my, I would highly encourage you, even those of you who don't usually use them, is use those objectives to narrow it down to the detail that I'm going to test you over. Okay? So the next two, the ribavirin and pegylated interferon, these are old products. The problem with them is high toxicity. And you'll see that when we look at what you need to monitor them for and establish a baseline before and after, it'll show you some of the toxicity. Ribavirin and pegylated interferons are no longer recommended to use by themselves. You'll always see that you'll see ribavirin in combination with the older products. You almost always see ribavirin and interferon together with older products. So it's recommended that you do not use them by themselves any longer. So you would never put somebody on a regimen that was ribavirin interferon. Got it? Okay. Very important, again, third time I've said it, is that when you do an interview of a person who's treatment experienced, you want to know, were they on those two products? Usually it is. I never saw a patient who finished it. But now I saw small groups. But the interferon is really a difficult drug for people to take. The depression from it is significant, and a lot of people just could not sustain and take it in order to achieve a cure. The good thing with the direct-acting agents is that their cure rate is 100%. So you can cure this disease. And I'll show you some things as we go through, is that even in people who have advanced liver disease can get huge effects from being treated. The problem you'll run into is that they're very expensive. So sometimes it's hard to get people treated because of the expense. But identifying them, and in every case that you can, if you treat them, if they're treated and they're cured, they can't pass it on. So that's huge. So if you're dealing with a drug abuse group, a group that tends to have, does not practice safe sexual practices, you need to keep in mind and think about these and treat them. Ribavirin is weight-based. So if you're going to use it, the guidelines it'll give you based on their weight, it's always going to be used in combination. And it's mostly when you get into treatment experience and they have cirrhosis, they will tend to add ribavirin into the mix. Pegylated interferon. So pegylation is a chemical process where you take PEG, polyethylene glycol, and you attach it to a drug. For some reason, when you do that, it solves a lot of the problems of drug use. It may make it more stable. It may keep it in the body longer so that you don't have to administer it as frequently. It may decrease the toxicity of drugs. So as we go through a lot of the biologics, especially for IBD, you'll also see pegylated drugs come up. It's recommended that if you are going to use an interferon for Hep C, you use a pegylated interferon if that's what you have to do. Okay. Pegylated interferons and ribavirin are less expensive. So you may be in areas where you will be forced into the use of those drugs because of cost. Okay? But you would always still add or have it in combination with one of those direct-acting agents. Okay. If you look under the pegylated interferons, you see under the combinations, the indications, so mostly in compensated liver disease as a part of a combination regimen with other antiviral agents, those direct-acting. You would not use it in somebody who had failed it before. So if they failed an interferon treatment regimen, you would not use it again. Okay. Look at the lab. So these are the baseline. This is one of your objectives, is a CBC. They're fairly, they hit they're myelosuppressive, so they will hit the bone marrow. So the anemia, neutropenia, all lines can be affected. Pregnancy test, ribavirin has a very high, is very teratogenic, so it's recommended when using it, they use, I think they recommend 2 very effective birth control products. Glucose testing, because you can have a worsening of their diabetes, thyroid the same, and also eye exams. So here's the list of adverse reactions. This slide is really good. It shows you kind of the timeline. So IFN treatment, so that is using a interferon. Here's severity, so flu-like symptoms early on. Throughout, you can have myelosuppression, so early on neutropenia, thrombocytopenia, and then anemia long-term. The fatigue is overwhelming. This is just that I'm tired. It's like I can't get out of bed tired or fatigue. It's very overwhelming. The fatigue and the depression, at least in what I've observed, are the most difficult for patients to sustain long periods of time, for up to 12 weeks. I see some of you shaking your head. Have you dealt with these patients? Have you had experience?
I have.
Amy?
Mm-hmm. I worked on a lot of, I worked on a lot of clinical trials for almost all of these drugs that you're mentioning as a regulatory specialist, so I didn't see a lot of patients. But when it was in 2013 when I started, and they were weaning out interferon because depression was so severe.
Yeah. It's hard drug. Effective, just can't get people to keep taking it. So drug reactions, alopecia, migraine, sudden hearing loss, flu-like symptoms, fatigue, nausea, derm complications, some of them are listed in the next bullet, infection, so it's an immunosuppressant, all type of fungal, bacterial, other viral infections are possible, ophthalmologic disorders all listed there, so vision impairment, vision loss can occur, and I don't know why I didn't put depression under there, but you should have had depression. Questions? Okay. If you look at, let's look at page 7 and then we'll take a break. So in terms of the characteristics, what they've done here is they have looked at each of the classes. So the protease inhibitors are the NS3-4A. The nucleoside polymerase inhibitors and the non-nucleoside, that's that NS5B, so the next 2 columns. And then the last column are the NS5As. So if you go down through there for potency, you see that the protease inhibitors, very potent. Barriers to resistance, you see the NS5B, the NPI, sofosbuvir. Buvir is high resistance to, high barrier to resistance. Anytime you see protease inhibitors, I don't care what you're treating, high drug interaction group. Always look them up. It's kind of like with amiodarone and warfarin and rifampin and the macrolides. They're all high interaction. Toxicities are listed there across for you. Dosing. The one good thing about the newer agent combinations is they have pretty much got it down to once a day. Adherence in this group is huge. It's like with HIV, you'll find adherence is everything. Taking the drug the same time of the day. With HIV, hours matter. Here, it's taking it, and now they've gotten the duration down, they've got it down to 1 dose, and they've got it daily, and they've got it down to where the drugs have very low side effect. But it's take it, take it, take it. So reinforcing that. If you're seeing these folks, always assessing adherence. It's the same thing with patients with HIV. I saw quite a few of them in the diabetes clinic because some of the drugs can cause a drug-induced diabetes. The biggest thing I was always like, are you taking your drug? If they're not, getting them plugged back in. They lost their funding, they lost their insurance, and so they quit going to the clinic. Or they just burn out, they just get tired of having the disease, and so they quit going to the doctor. So it's getting them plugged back in. Adherence with antivirals is really important. And then there's comments there at the bottom. Okay, so we'll take a break. We'll start back at 4 and we'll talk about management.